Thank you. Ladies and gentlemen, I'm back, and we're going to have an interesting podcast today. Thank you so much for joining us on stage today. Ladies and gentlemen, we are going live on YouTube right now, okay? So we'll be talking not just to you guys, but also to our audience, Medical Channel Asia's audience on YouTube as well. And if you want to know where we're streaming from is that little handphone over there that's pointed at you guys, the speakers, okay? So let's address the crowd sometimes as well. Okay, we have a lot to get through and we have very little time. So let's make sure that we have plenty of time to talk about this. Chatting with Dr. Ramon as well as Dr. Melvin earlier. This is a topic very, very close to their hearts, right? The interoperability of digitalization. And as we learned just shortly earlier, big difference between digitalization and digitizing of a product. So I'm going to jump straight into the conversations at hand. And I want to start by letting each of you have a few minutes to just share your thoughts on this subject, and then we'll do some questions later. All right? So I think maybe we start with Melvin. Go ahead and introduce yourself, and let's go. Get that mic going. Okay, I have it. Okay, good. Yeah, we can hear you loud and clear. All right.
Testing. Okay, that's great. I think I'm preaching to the converted here. Everyone here is already kind of converted on this. That's why we're here. But I think to the unconverted masses, sometimes trying to get digitization and digitalization in an organization is trying to explain to people that I need to put on an airport and nobody has seen it directly. I think we understand that pressure. It's like everyone is walking or taking a train, and you're saying, no, that you can fly, but you need to build an airport first. And getting the traction, the support in order to build that is always a challenge. And I hope we can learn more from my fellow panelists about how to explain to people that we need to build an airport.
Awesome. That's a great start. That's a great start to this conversation, Dr. Melvin. Yeah. Dr. Ramon, you want to start with just a few thoughts on your side before we jump into the details here?
Guys, good morning everyone. Thank you, Jason. Thank you, Medical Channel Asia. It's good to be here today to share
Testing.
like Qualitas, I represent Qualitas in Asia. Qualitas is in 3 different countries, and the journey for digital in Qualitas actually started back in 2017. And 2019, we embarked on an EMR in all our clinics, right? So since 2019, Qualitas Malaysia has been linked by our own purposeful EMR. I know Dr. Mike is saying just take off the shelf, but there were not many systems off the shelf at that time, and to cater for the large or varied modalities we needed. Now, the challenge was prior to COVID, as Mike was saying and as Dr. Hen was saying, adapting doctors to digitalization was not easy. Doctors in general, as a medicine as general, is a very traditional practice. It's a patient-doctor relationship, touch, feel, look in the eyes, empathy, sympathy, etc. Switching them to digitalization was not easy. And so we embarked on it, as I said, 2018, 2019, and we were a full rollout just prior to COVID. But immediately when COVID came over, we saw this push for digital health. Back then, telemedicine, nobody wanted to do telemedicine, how can I not see my patient, etc. But the moment COVID came, everybody jumped on the bandwagon and things moved very fast. Now, the situation that we have today is that adoptability, I don't think, is the problem. I think I was in CCAPS before in Putrajaya 10 years ago when we only had about 7,000 clinics, private practice. But to my share, only one from the government here, the rest of us are in the private. So I think you're preaching to the choir. I think the private sector is moving ahead. We have all adopted digitalization. We have invested. But I think the biggest question is where ROI comes from, right? Because there's only so much money you can put without getting anything back. And hence where the topic of interoperability comes to factor, because that is when we will see the ROI and where we will see patient integration, understanding, work doctors having mutual respect for each other and working together.
Dr. Rahman, thank you so much for that. That was a great introduction. And on that topic of pushing ahead in the private sector, I think Sharil showed me a video just a few minutes ago of what KPJ is doing in terms of technology. It's really impressive. Talk to us a bit about your work there.
It's moving. Morning, everybody. I think the ideation of digitalization is something that talks about the future. And I think in this room today, we have many leaders and also future leaders. And I think the fundamental of making sure that those are being adopted is by us, by leaders and future leaders, right? We need to embrace, we need to walk the talk. And the thing is with future is everybody's going to be afraid of doing so, because something that has not been done before, people talk about it, and sometimes you need to visualize. So what I did to share with Jason just now, how the future looks like. And I keep talking to all my, not just my colleagues, but also my partners, my collaborators, is that how does this future look like, right? And I realized that I need to continue to visualize that to my audience. And my audience could be many, right? Could be clinicians, could be hospital patient administrator, consultants. Those are the things that and within that 2 minutes the video that I showed to Jason realized, wow, is that the impression that you had?
It's really very impressive because they're thinking about this from the start to the end. Exactly what we're talking about from the start, the very first click, all the way to the journey of registration, all the way to the medical records, right? I think that was what was impressive about it.
I think the idea behind is making sure that all things that we're deploying is to serve one thing. It's basically my mission, right? KD's mission, right? So ensuring that I do not miss out, we do not miss out any elements of digitalization in each part of the journey. What we did first was build that patient journey from the start of why the coaching mentioned this morning, which doctor should I meet, right? Now we have a single platform that allows patient, future patient, potential patient, to even look at those characteristics or profile of those doctors, identify where he should go and on. All the way after this treatment at home. So that video that showed Jason was all about that, right? I think that's very important, right? We'll be able to talk about those kind of things that's going to come in the future and visualize it is very important, especially when we have the civilization of citizens in Asia that's not had input or actually have an understanding of what the future looks like. Just why I'm so interested, right? Back in the early 2000s, I was in the UK and NHS, National Services. They were the first country in the whole world to actually not just digitize but digitalize the patient care records. For 16 million patients, they're trying to actually figure out how to decentralize the whole thing, improve patient care. NHS was not about patient care or actually not about making money, but over there during that time was actually reduction of patients actually not be able to be treated when they come to the A&E. So we're able to actually look and focus on that, right? And today I think in KPJ, we're trying to embed that together to make sure that we can continue to improve patient care through digitalization.
Thank you so much for that sharing. Yes, and I hope at some point KPJ puts that video out somewhere where everyone can see it. First thing I asked Sharil is it on YouTube? And he's like, not yet, and you guys need to get that out there, okay? But Sharil brings up a very good point. At the end of the day, everything we do in this, in the work that we do is for the patients, for our audience. Speaking of our audience, Medical Channel Asia's audience is live on YouTube right now. So let me just remind those who are just joining us live on YouTube right now that we are on a panel here at Connecting Care with Clicks 2025, okay? And we're having a very interesting discussion about powering the future of Malaysian healthcare and the interoperability, AI, and digitization, okay? And now I'm going to take the conversation back to Dr. Melvin and put my question over to him. And the question I have for you, Dr. Melvin, is that Thomson Medical Group obviously operates across multiple countries, very familiar branding to all of you, right? Thomson Medical Group, and multiple countries in Southeast Asia. And from your perspective, what are the biggest challenges opportunities when it comes to implementing an interoperable digital system across borders, especially, and within the hospital groups.
Thanks so much, Jason, for that. So, Thomson article, we have 3 geographies: Singapore, Malaysia, recently Vietnam, with hospitals there, and also IVF clinics. To be honest, the interoperability between geographies is quite clear. There are certain policies and government laws. But to be honest, most of the friction actually comes sometimes even within the country, interspecialty, within the hospital, even within professionals. Let me give you from small to big, okay? In some parts of the world, the doctors are private and the hospital is a facility. And when the doctor does a test in a private clinic, and the patient then subsequently needs to come to the hospital and get admitted, you don't get the interoperability of the blood test. So sometimes the opacity when the patient comes to the hospital becomes an issue. So I think policies and changes to government organizations are starting to change that, where I think there's submission of information on that test so that when the patient comes from a different clinic, they're able to get the information. And that comes down to policy like data sharing laws. That has been implemented in Singapore, and I think the national electronic health record of many countries is becoming something that is being considered. Something that Dr. Mahesh talked about just now very interestingly is digitalization and digitalization, something like that. And if you take paper processes and just make it glorified electronic paper, you get the same inefficiencies. For example, if you wanted to run a clinical trial in just one hospital, and the data comes from the Department of Pathology, which comes from its electronic filing cabinet, you need to get the head of the department to approve for his data to be shared in the hospital so that you could run the trial, because you want to have data across labs, you want to have pathology data, you want to have clinical data, and that becomes an issue as well. So actually these are amplified across geographies, and you get the same amounts of issue. But for money companies that are running across geographies, I must say that actually it comes down to the objectivity of what you really need to run your business across geographies or across sites. To be honest, do you really need the hour by hour, minute by minute blood pressure of the patient? You don't. So the type of systems that you need to build, digitalization systems that you need to, or data warehouses that you need to build, you don't need to account for such granularity. And I think being objective and not having to say I need everything would be important and interesting. The other thing that we have been grappling with is the amount of variability and of systems is just crazily complex. Now, even within the radiology information systems, there will be a few vendors. You might use, even within a hospital, Siemens, or even United Imaging, or you might be using GE. And then for your lab information systems, you'll be using Roche, you'll be using Abbott, you'll be using Siemens. And that complexity, you start to ask questions, can I build multiple APIs and connect them all up? And every time the version changes, you build more APIs, and you break APIs, and this causes cybersecurity issues. You get vendors talking to vendors, and you don't know what the vendors are talking to each other about. And I think the need for actually having the data warehousing, healthcare information systems backbone, and then having more control over the flow of data is becoming increasingly important in this day and age where, cybersecurity is becoming pretty paramount. I guess the last thing that I would like to talk about is also sometimes being practical. I have a story that I want to talk about. I had a data project last time with IHH, I was with this company, and we were working with Sweet. It's like, we need to get the data from the clinical record because we want to understand what the doctor is doing so that we can do certain data initiatives. And the problem that we had was that the doctors were not contemporaneously putting in data into the EMR, right? Because we're all busy. It's at the end of the day, you might remember some stuff you put it in. So the data actually wasn't very well documented in electronic medical record, right? And then we were like thinking, what should we do? And then we realized actually the billing system is pretty good. People might forget to put clinical data in, like regular billing for what they've done. And actually, we found that the billing system, the finance system, was actually a very good understanding of where the patient was going. There was more oxygen used, the patient deteriorated, iron flows were administered, was being prescribed. We can tell the story just by looking at the bill instead of looking at the electronic medical record. And that became a very good substitute for us to actually build systems and patient storage, patient journeys around it. So, yeah, sometimes we just have to be practical. Where's the best form of information we can get?
That is such an interesting insight. So you're literally extracting so much of that patient's journey from that last mile of the billing part of it. That's really interesting. Thanks for sharing, Dr. Navin. Your experience obviously transcends borders, transcends multiple hospitals as well. Dr. Ramon, your experience is slightly different, although you were mentioning earlier when we were just chatting down here at the front that, Qualitas has done a lot to develop things for within your own space, but yet you see how it's such a drop in the bucket when you're looking at the entire ecosystem of it, right? Yeah, please. I wanted you to talk to us a little bit about how is Qualitas addressing, the lack of digital maturity in the primary care level, and what will it take for GPs to become more active data contributors? Dr. Marvin mentioned that as well. They are not putting the data in, they're not getting any data out as well, right? And in this connected system that we have now.
Thank you, Jason. In context of Qualitas, I mentioned earlier, we embarked on this 7 years ago, but the process is not easy. Like what Dr. Melvin said, getting doctors to streamline what they put inside. Just for diabetes mellitus, we can have 10 different types. Diabetes mellitus, leaching type 2, DM2. So this is not working for digitalization because it needs to be coded. So what do we use? ICD-10, ICD-11. So this is where I think when you mentioned digital maturity, it's a good word. The maturity part comes with guidance, right? Like any child who's growing, as you mature, you need guidance, you need input, you need support from a village. Right? You need, I think the adoption of the private primary care side, I think, is way above KKM. I think it's not 0.1%, right? I think we are close to 70 to 80%, I would say safely, in the private primary care space. I think almost every clinic today will have some form of system, digitalization, and I think it's a matter of what feeds into the system to increase maturity. So how is the doctors trained? Do we have a system? Do we have a policy? And hence, as I was discussing with Dr. Mahesh, I was asking him, when will that policy come out? When will that policy come that we will use ICD-11? Or is there a primary care diagnostic tool to use? Because the ICD-10 or ICD-11 is, I think, 5,000 different diagnoses there. And I think only for GPs, I think we just need maybe 100, right? We don't need more than that. So how do we streamline that? Because, immediately we're talking about the future of healthcare. And AI is the buzzword, we're not talking about AI. But AI is only based on what data goes in. If the data doesn't go in correctly, you don't need the data to come out to develop the right algorithms. Right? So rubbish in, rubbish out. So how do we get the right data? So there needs to be a policy, there needs to be an understanding on the primary care level, on the secondary level, tertiary level, allied healthcare. There needs to be that framework of what we need to adopt. So when we talk about digital maturity, Jason, we can only go so far. We have spent millions of dollars on our EMR, but we are not getting any ROI. Nobody's paying me 5 ringgit more for my EMR, right? So that's another pushback for GPs. Because as the Qualitas, because we can afford it, so we what about the sole GP? What about the sole GP? How is he going to invest further? Where is his ROI coming from? If he wants to digitalize, yes, he can. But what benefit is he going to see from it? Just to take this, the last part about it is, I think, we actually adopted a radiology AI many years ago in partnership with AstraZeneca for early detection of lung cancer. It's fantastic, right? We get QAI, we get reports in 10 seconds, very detailed, but we understand it's a machine learning system. So doctors still are the gatekeeper of that. So doctors cannot be scared, as Jason said, pick up that surfboard, adopt digitalization, and ride the wave and enable it.
Thank you so much, Dr. Rahman. That's an interesting point because we talked a lot about ensuring that this brings value, right, to the patient, but you're talking about a point where it actually needs to bring value to the healthcare provider as well, right? For the incentive to be correct, for him to push on in this. Now, I want to take the conversation over to Shahril, okay, because Shahril sent me today is 280 what day in the 258 days as the Chief Digital Officer of KPJ, and all of you know, yeah, big hand to him, yeah. I think it works, okay. So, he has 258 days as the Chief Digital Officer, and obviously, you know, you have encountered a fair share of challenges in the last few days. Tell me, what are some of the biggest lessons that you have in terms of aligning digital systems across the departments and facilities of KBJ?
Thanks, Jason. Yeah, today's 250 days. People ask me why, I think when we have a mission and actually supported by key stakeholders, I think the days allow me to really focus on what I need to achieve more. And my shoulders doesn't give me time. Just like in the next 360 days, 3 years, we're going to do this. So the question is about what we're doing in terms of our KPJ, in terms of making sure that all of this are being used in the interoperability, right? Dr. Nabi mentioned just now, just a bit, quick one, right? So KPJ has about 30 hospitals.
Massive.
In the region. We have about 4,000 beds in terms of size. We are definitely the biggest. And all these hospitals that we have today actually comes from 3 different types of ways. One, we built to be required, and third, actually do a GV with a third party to actually run or operate that hospital. So there's different type of type within our ecosystem. And I think, what Dr. Nabi mentioned is not even for types or modalities, right? We have different brands. Our EMR will actually have more type, but these are all not connected, right? I think the vision is to actually allow us to one day, most likely, to be able to have one patient on record that allow us to integrate our data. I think the lessons learned is actually most likely the importance of getting those data together. Because without data, people talk about interoperability means the ability for them to connect, and communicate, and to share those insights, right? So I give you an example. Today, all of these participants are coming from different countries. The only thing that actually connects us together, most likely one that's common, is language, right? So language is very important. I mean, the ability for me to share information because we are all able to communicate in one language. So what Dr. Nish mentioned, if you look at the slides, there are one terms called OCD and Dr. Rama mentioned about OCD, ICD-10 level, right? Those are international standards, right? So in order for us to make sure that everything comes together, connect together, the ability for us to standardize is very important, right? And unfortunately or unfortunately, in KPJ, we actually driving through this, even though currently we do not have, say, for example, national standards of doing that. I think KPJ wanted to make sure that we continue to do those things. Fortunately, because healthcare is very governed, just like banking, right? There are standards, international standards that we can apply. And this is where I believe KPJ later on will be able to collaborate with, let's say, language, other private healthcare providers to come up with that standardization for our country. So the lessons learned, I think, is number one is making sure that there's standardization, right? And if we can lead, we want to do that. Today, we have 30 hospitals, or 40 years of history, about 10 million patient records, digital. These are digital records that we have. And that actually have many types of data. So Dr. Mary mentioned about lab data, we have that standard. And in terms of lab, we have the standards. They are all standardized, right? Unfortunately, it's not integrated. So number one is making sure there's standardization. Number two, I think that's going to be very important in just how we govern and protect us. Right? People keep asking, right? Yeah, because you don't want to say, for example, Shahril Arifin, have high blood pressure because of working with KPT, for example, right? So you don't want that, right? So I think those needs to be protected, right? When I was in NHS, protecting royal data, in the UK, huge, right? We had a special room just to protect. So number one, there need to be licenses of those patients. The late principles is not safe things, but it's a special scrutiny, right? So there's many terms of measurements to make sure that, and in Malaysia we most of the safety. So protecting and governing the data is going to be very important. Last but not least is this, is making sure that it doesn't become one. Dr. Mahesh gave a good example, right? In 1957, NHS started in 2000, means Malaysia had the first, right, digitalisation application within the healthcare system. When I was there in 2000, that was when we started, right? I didn't realize in 1997 we had one slide, we started it. But do we grow and create value of that? We didn't, right? So I think this is where I think the ability for us to contribute, that making sure it doesn't continue to be wide open, is going to be something that we really need to think about and making sure, right? So, and I think it's all about making sure that the patient or the user experience is very important. Our EMR, for example, is a lot of doctors, right? So Dr. Melvin just now mentioned that, okay, a lot of doctors, when they do diagnosis of patient, the ability for them to key in is like very slow. I've seen it's very good. Use one finger and start connecting, right? So our HRs in KPJ will do two things. Number one, ability to turn off speech to text. So you focus, so the doctor is going to focus the conversation with the patient, and then convert all of them into text, supported by AI, making sure that those diagnoses are fully supported. That's number one. Right? Then the second thing is actually you want to, and a lot of doctors have to draw a lot of clinicians, right? When you actually, if you're a cardio, if you're an ENT, you like to draw and see what it is, right? Now we are templatizing that. Templatizing that you really speak instead of like drawing, we give you your iPad, right? You just draw and take a note of that. And it's seamless, right? Can you imagine our first source where information is to come into the system are being supported, are being given so much freedom and support? They'll continue to do that because fundamentally it's important for us to do that. Yeah?
That's really interesting because you bring one of the values to the HCP very clearly to the front, right? We all use this speech-to-text recognition AI software nowadays to record our meetings, digest our meeting notes and all that. Why shouldn't they as well, right? In the healthcare system.
100%, because I think that's where the whole thing comes to. I mean, the diagnosis is the source or the start of everything.
Yeah.
Right? I think that's important, right? But I did something for Dr. Melvin which I have not thought about. Thank you for that. But looking at financial data, it's true. If you go to any private healthcare, it's important. The case was not so important, but the financial, the billing is going to be very high. I think that's a good point. I'm going to go back.
That was a key thing.
Yeah.
The billing tells you the whole story.
Yeah.
Guys, this has been a really interesting panel, and all three of these speakers will be around most of the day, I hope. And I'm not going to open the questions due to lack of time because I think they'll be around to converse with you. But I felt like along the discussion, I felt Dr. Mahesh's name came up very often in the discussion. I just wonder if you would like to add any words to what was discussed so far. Can someone run the mic over to Dr. Mahesh, please? I feel like he was nodding, he was engaging. I feel like he has something to say, so let's hear it.
Thank you very much. Nothing much to say, but just the most important key takeaway here is standardization. If you want to interoperate, you need to come up with standards. Like what you said, Dr. Raman, it's 0.1% is government, not private. Although 70% of our private GP friends are digital, they're just digitized, they're not digitalized. So today, when I say I want data, I want to say how many diabetics came to my clinic, how many of them have got abnormal glycosylated hemoglobin. Out of that abnormal glycosylated hemoglobin patients, how many of them have got abnormal hypertension? And to move one step ahead, we're talking about descriptive stats, predictive stats, and eventually prescriptive stats. How many of them I can actually send targeted messages? You say, hey, you guys are going to probably end up with myocardial infarctions in Dr. Sri is actually in Nigeria soon. So these are the things, these are the insights policymakers want. Right? So that's about it. And return of investment, very, very nice. People think digital health does not give you outright money. Of course it doesn't. In the financial lens, we call this preventive cost. How much these can actually help? Because I remember a surgeon a surgeon once told me, hey, I'm not going to use the system if it takes 1 minute of my time extra. So I'm like, okay. But your 1 minute of your time that you took extra actually could save lots of other minutes in other departments. You actually save lots of time for the patients, right? So the ROI is just not how much money I get in return, but how much more lives I save, how much more experience I can provide for patients. And Dr. Melvin, Sharia, you were talking about standardization, and I'm so happy to hear all this because We are, as a government servant, as a loyal government servant, we are so happy to see now the uptake of digitalization, having leaders like you in hospitals, in the private healthcare space, Dr. Rahman, how now we can collaborate with each other. It's all about, again, one important thing, the patient. So be a digital driver, be a digital enabler, change your analog minds to digital minds. Thank you very much.
Thank you very much. Yes, Shahril is saying that he wants to share something. 30 seconds, later.
Might be longer, but I think it's important, right? How digital and how improve, like say, patient care journey. I mean, even the notes, imagine this, right? I think for a fact, I mean, knows in Malaysia, the two main, like say, kind of disease or diagnosed like a patient, a person who has actually diabetes and also hypertension, right? So these two actually three things that you take care of: your rest, what you eat, and what you drink. Imagine, let's say, for example, when you want to go to a restaurant, you want to eat, and we are tracking what kind of intake, the salt, sugar, and all, right? There's an app that moving forward, they actually have that. You go to a restaurant, you go to a door, you have an app, KTX, so that you go free. So then it connects to the door, right? And you scan it. So by the time you go to the table to eat, on average, right? A good restaurant will have about between 50 to 100 items. So you have starter, main course, appetizer, dessert, drinks, and all. Knowing the system, knowing your body, right? How much takes that you allowed to. Then actually, before you even look at the menu, my apps prompt you, Shahril, out of these 109 items of food and drinks that you can have, only 27 actually you can choose. Because of the amount of sugar content you have. It's not telling you you gotta do, but it's telling you the options that you have to continue to have better life, right? And then basically it's up to you to choose, right? And then basically you do it every Friday. Let's say you do it every Friday or Saturday, or Saturday only I'm here, but every Friday, Saturday. On the third or fourth week, on Wednesday, the apps then prompt you, Shahril, I know that you're going to go eat dinner at this place, or actually want to have dinner on Friday. On Wednesday, it tells you based on your sugar content, or salt content, and all. Right? On Thursday, you should not eat any of this, or you shouldn't drink it. I'll give an example. And it tells you right, exactly what you need to take or not take, so that you can actually have what you want on Friday. Now that's the vision of what we want to do at KBJ. In terms of not just taking care of a patient, but also for the whole of Malaysians. I think that's what we're focused on.
That's really interesting. Taking the technology out of the care setting and taking it along with you. Yeah. I hope your app can tell me that I can eat the burung mantu that I'm thinking about.
I'm gonna give you some.
Alright, guys, I want all of you to put your hands together and thank the group. Thank you so much. That was really great. Thanks to those joining us on YouTube as well, Medical Channel Asia. This clip will be up on our channel later if you want to review it and look at the questions there. Can I invite three of you to stand at the edge and let's take a photo together before we go down? Alright, our photographer is right here. Okay, nice. Thank you once again, Dr. Melvin. Thank you so much for the time. Appreciate it. Thank you for everyone. Thank you very much.
Yeah, big thank you to all the panelists for that insightful conversation. So I know there's a lot of green juice being used this morning. So we're going to take a short break and we'll be back here at 10:20 for our next session on medical tourism. So head out, recharge, get some refreshment, coffee, and also visit our exhibition booth and photo booth as well. See you back here